others will be coming in as we cross over the noon hour. And so just in the interest of time and knowing we have quite a significant discussion to get through, I'll get us started. I'll just say good morning and good afternoon to everyone out there in Medical Alley and around the world. Thank you so much for spending a little bit of your day with us today to hear this discussion, to contribute to the discussion, and hopefully to come away with some new ideas and insights. My name is Frank Gistalti, and I'll be your moderator for this discussion today. This is the third of a three-part series that we've been doing in partnership with the Association of Black Cardiologists and the Preventive Cardiovascular Nurses Association on the topic of race, socioeconomic status, and cardiovascular health. In our first two podcast discussions, we looked at the topic of obesity and the topic of peripheral arterial disease, or peripheral artery disease. Not a fun word to say for someone who's got a little bit of a lisp going on. But we looked at those two topics, and we were really focused on setting the stage of what are the issues that we're seeing right now in the country. And in this webinar discussion, our fantastic panelists are going to continue that dialogue, but look a bit more at what is happening today and what might we do in the future to better address these issues. As we go through this discussion, just a couple of quick housekeeping items. One, if you've got questions, use the Q&A function that's in the tool. I'll be monitoring those, and I'll try to bring the questions in the discussion as appropriate. So anytime, don't wait till the end, just type them in. I'll see them up on my screen. I'll try to pull those in. The second, the webinar is being recorded. That's usually the most common question we get from the audience. It will be sent to you following this, probably early next week, so that if you want to replay it, gather new insights, or share it with your colleagues, you'll have that link. And then third, if you have ideas for what we should do next in this sort of conversation or other topics that we should address, please do reach out. Everything that we do comes from you, from the community, telling us what we should be discussing, what policies we should be addressing. We always are looking for your input. And so with that, I'll get started with the more enjoyable and more important part of this, the discussion we have today. And I'm going to ask that our panelists start just by giving a quick intro of themselves and of their work. And Chloe, since you're unmuted at the moment, I might ask you if you'd start with giving us an introduction to you and your work.
Okay. Well, thank you, Frank. My name is Chloe Villavaso. I'm a clinical nurse specialist, which is an advanced practice nurse here in Louisiana. I work for Tulane University School of Medicine. And my clinical focus is preventive cardiology. I am a member of the Association of Black Cardiologists and the Preventive Cardiovascular Nurses Association.
Wonderful, thank you. And as someone in the association world, I appreciate a person who's active in multiple associations. Dr. Bond, if you would.
Absolutely. So my name is Dr. Rachel Bond. I am a preventive cardiologist out in Phoenix, Arizona. Over there, I oversee a women's cardiovascular program, and I've been doing a lot of work on health equity as well. For the Association of Black Cardiologists, I'm very fortunate to be the co-chair of the Cardiovascular Disease and Women and Children's Committee, and I also am very fortunate to sit on the board of directors for the ABC.
Wonderful, thank you. And Dr. Fakarini, if you would.
Sure. My name is Felicia Fakarini. I am an interventional cardiologist here in Cleveland, Mississippi, the heart of the Mississippi Delta. Basically came to the Delta 7 years ago to start my practice, both cardiovascular, meaning heart and vascular focus, in terms of addressing inequities in care, given the prevalence of disease here in the heart of the Delta, and some of the inequities that you see across the spectrum, both in the patient lens, but also community and provider lenses. And so it's led to my involvement in a lot of societies, but I'm currently the co-chair for the PAD initiative here at the Association of Black Cardiology. And I also sit on different societies, including the Society of Coronary Angiography Intervention and American Heart Association. I'm privileged to be here. Thank you.
Yeah. Maybe we'll start to kind of building off what you just shared, Dr. Fakarini, a bit. Dr. Bond, I might ask you could you start with just setting the stage of what's the current state of affairs as far as the scope of cardiovascular disease, and in particular as it affects communities of color. And I would also open this question up to both of the others as well to give their perspective, but starting with you, Dr. Bond.
Yeah, I think what Dr. Federighi said just is very powerful in the sense that we want to think beyond just the actual heart itself. When we think about cardiovascular disease, we know it's an umbrella term that implies the cerebral vasculature, such as a stroke, or risk factors that can lead to a stroke, such as also coronary artery disease, but also the vessels in the arms or even the legs. And all of these are conditions that, although highly preventable, right? The statistics show that 80% of cardiovascular disease is preventable. We're seeing higher and higher rates, and those rates are disproportionate to communities of color. And we know that many a times these are from conditions that are risk factors like high blood pressure, high cholesterol, diabetes, things that we can easily manage just through a lot of times lifestyle, but also ensuring that there's equitable care to appropriate management, appropriate medication, even sometimes appropriate procedures. And when we look at the scope of the United States right now, we know that there are glaring data that shows, not just from a race and ethnic perspective, but even from a sex and gender perspective, that there are disparities in a lot of the treatment that we offer patients based on their background. Why this is, and when we think about the actual scope of health outcomes, we know that 80% of our health is dictated by social determinants of health, right? Where people grew up, where they were born, and where they live and play and pray. And many a times at the core of those social determinants of health, the thing that leads to negative social determinants of health is systemic racism. And I think it's very important for us to highlight that racism, not race, is unfortunately many a times the answer to a lot of the questions when we're asking, well, why are we seeing these higher rates in this population versus the next? So I'm fortunate that to be on this panel where we're having these hard conversations, because it's important to highlight that the sole purpose of this is really to get the messaging out there, because there is a way for us to identify these overall conditions, but more importantly, change the way that we're managing many of these higher, vulnerable, disenfranchised populations.
Indeed, indeed. Dr. Fakarini or Chloe, anything you would want to add to that?
Sure. To Rachel's point, I think it's not just the social determinants, but the political determinants that determine the social determinants, right? So what are these drivers when we talk about policy that led to the social determinants in the first place? And how did that either exacerbate or empower or create these inequities in care? And how did they prevent advancements in bridging the gap in health disparities? That's why policy is important whenever we talk about clinical, economical, and human impacts of cardiovascular disease. For instance, in peripheral arterial disease, where we all know the drivers are, and those risk factors that are undertreated and undermanaged and underdiagnosed are more predominant in communities of color. This has existed for decades. We're not saying anything new on this webinar today from that standpoint. What is still shocking, and to what Martin Luther King said in the 1960s that still exists today, is that in spite of all the technological advancements we've made, all the advancements we've made from both the pharmacotherapy standpoint, from the device standpoint, from teaching standpoint, in healthcare, across the cardiovascular space, when you look at diabetes, hypertension, peripheral arterial disease, amputation rates, heart attack rates, over the last 20 to 30 years, we have not bridge the gap significantly when it comes to the morbidity and mortality rates of underserved and communities of color. We have not done that in spite of all these advancements. Why is that? And that's the question. We've asked this question on a personal level and societal level. The answer is what Rachel said: structural racism. And it's an uncomfortable conversation to have in certain circles, in certain societies. But we have to understand that there are political determinants and social determinants and personal determinants that drive all this. So we're here to continue that conversation and work with our colleagues from a collaborative standpoint to bridge the gap, but also to answer solutions.
Indeed, indeed. And Chloe, anything you'd want to add to that? Oh, and you're on mute.
I agree wholeheartedly with the comments from Dr. Fakarini and Dr. Bond. As I was preparing for this presentation today, I did learn what Dr. Fakarini mentioned about since the 1960s, the mortality gap between the white population and Black population has persisted, and that's quite alarming. In my work, I do a lot of community efforts around education and blood pressure screenings, particularly through the PCNA. And one thing that we do know is that racial and ethnic minority groups have lower rates of blood pressure control. And hypertension affects Black individuals at a higher rate. It's more severe and it presents earlier in this group. And so these are things that we need to acknowledge and come up with ways that we can address these issues and try to improve these inequities in healthcare.
Indeed. And I might stay with you for a moment, but I'd again ask this of all of you. And you've all pointed out these issues have existed and persisted for a significant amount of time. Dr. Bond, you pointed out that we have therapies that we know could work, but there are larger issues, particularly structural racism, which Dr. Fakarini, I appreciate bringing the policy and political dimension into it. Recently being maybe just the last couple of years, this topic of health equity has become a discussion more generally, not just within the Black community or communities of color that have been impacted by this for so long. So I'm curious, has that had an impact? There was mention of raising the issue. Has that broader discussion made progress or started us on a path of progress, or is it still not? I suspect it's still not enough, but has it started us down a direction that's positive or not?
I think we're moving in the right direction. However, the issue of healthcare disparities is multifaceted, and it's going to take many efforts from various angles and consistent efforts. This is not something that we're going to solve in one clinic visit or 1 year's worth of work. It's going to take a team effort, collaboration, multidisciplinary to move the needle and see change.
Well said, indeed. And I think something I'm sure we'll talk a bit more about are those specific things that are starting to happen, but it's something I think we don't say enough to the broader political community and general healthcare community is what you just said about the long-term component of it, that if these are problems that took generations to develop, they probably won't be solved in one clinic or 1 year. Maybe just staying with you for one more moment and then coming to the others. You mentioned that community engagement piece. What role does that play in affecting change? And do you have any examples? And I'd ask everyone of this, of where maybe that has started to make some impact that we might learn from.
Oh, absolutely. Some of the efforts that the Preventive Cardiovascular Nurses Association has promoted, we have multiple patient education materials that we provide free of charge to our members. We also promote PAD screenings and health education events. So in New Orleans, one thing that we've done with our local chapter here, the PCNA chapter, is partnered with other organizations such as Tulane School of Medicine, the New Orleans Health Department, Walgreens, the Healthy Heart Community Prevention Project, and other nonprofit organizations to provide flu and COVID vaccines to the New Orleans population, in addition to health education. And that effort has been very successful because we go out into the community where our patients are, where they live, where they work, where they pray, where they're comfortable, and we present ourselves, and they're able to come to us. We can give them the resources, the care that they need. And in that one effort that we saw that we were able to vaccinate over 400 people so far, and we're still not done. So it's very exciting when we see the community come to us. They're comfortable enough to come talk to us, ask questions. It can be pretty intimidating going into a clinic sometimes or into a hospital. So going out into the community is very, very effective. And one thing that I'd like to add, I was listening to the other podcast and they mentioned about community efforts. One thing that I feel that has made us at PCNA very successful is the collaboration with other organizations that have been out in the community and are well established. For instance, I mentioned the Healthy Heart Community Prevention Project led by Dr. Daphne Ferdinand. She has led this organization and has deep roots in the community. So for any healthcare professional or organization that's looking to go out into the community and wondering, how do I get started? How do I don't even know where to go. First, reach out to those organizations that have been out there in the community doing the work for decades and that have, seen positive results. And you can make those connections and bring about improvements that way.
Indeed. And Dr. Bond, anything you might add or examples you might share?
Yeah, I actually just wanted to make a point to your question about changing the structure. I think it's important that we acknowledge the fact that the healthcare system was unfortunately created with this intention in mind. So I think in order for us to really move the needle and see sound change, we're going to have to restructure the whole healthcare system. To that point, I would say at a local level, many of us clinicians are working to get the messaging out there, things that we've been doing well before COVID-19 hit, where people began to really focus a lot of their efforts on health equity. But beyond that, a big part of what we have been doing, even from back in the day, has been bringing in trusted community leaders, because we know that there's such a large number of mistrust in the healthcare sector because, again, the structure of the healthcare system has always been in the sense to really bet itself against those communities of color. So with that, I would say the Association of Black Cardiologists, they have made phenomenal efforts in really working at the core, those grassroots efforts in multiple states to really bring to the community, teach the members of the community how to educate on a lot of these modifiable risk factors, bring access to even something as simple as a self-monitored blood pressure machine to people that may not have the ability to afford such a machine, teaching them how to actually check their blood pressure, because we know it's important that we properly monitor blood pressure, but more importantly, that we're checking it appropriately. So the ABC, along with other organizations, have done, I would say, a lot of the grassroots efforts. They've also engaged barbershops, beauty parlors, churches, of course, but all places that communities of color have a tendency to feel as welcomed, but more importantly, they feel that this is a trusted member of their community, and bringing this healthcare into the community, I would hope, actually is going to make significant change and improvement.
Oh, indeed. And on that topic of the healthcare system built this way, I might put out there that would be a great additional conversation specifically on that topic, because I suspect that is something that much of our audience may not fully understand or appreciate, and thus not realize the kind of the silent structures that are out there that have made this more difficult. So I appreciate you bring that up. Dr. Fakarini, anything from you on this?
It's hard to follow these two ladies, but what both of them said are the roots of what we're trying to address and solve. We have wonderful organizations that have for decades been at the ground roots level. People frequently ask, how do we address this issue? And for me, my personal story and why I think the ABC serves as an example for this is literally, packing my bags and moving from the Northeast, New Jersey, and New York to come here to the heart of the Delta. To one, because 40% of the population here in Mississippi look like me, they're Black. Two, majority of these patients have conditions that are under the cardiovascular spectrum, but also they have the lowest access to providers. And having the ability to serve in a community that looks like my dad and my mom, or my brother and my sister, matters. We're having an organization that supports you in the process matters. Having resources to exact or to help them attain that fair and just ability to just live and attain the best health they can achieve is all they seek. But what's challenging is the fact that everyone thinks it's a one-size-fits-all model. No, it's not. So coming here and learning about the Delta and learn about the cultural differences and the geographical differences and how someone is easily afforded or given an amputation first strategy in an emergency room in the ER versus opportunities to save a limb or limb preserving strategies. That was the first eye opener. In spite of reading it on all the PowerPoints that you see in national conferences, but being on the ground and seeing it every day in front of you and having these patients present with their family members and learning how economically it has caused a generational scar, how clinically these patients are dead within 5 years. And from a humanistic standpoint, I mean, it's not only the mental anguish, but also the fact that this could be your mom, which is my mother, who has diabetes, or my dad, who also has diabetes. I mean, it's compelling. But the good part of this is if you engage in the community and these folks understand that, you care, you matter. It's not only the technical competences, the interpersonal competences, the compassion, empathy, and going into where they live and meeting them where they are and being culturally responsive to say, you know what, prevention is better than cure. I want to prevent this from happening. The reactionary healthcare system we have is not the solution. Meeting you in the ER is not the solution. Meeting you in the hospital is not the solution. How can we meet you at home or in your site of service or a place of worship so that we can prevent you from ending up in the ER? That facilitates care-seeking behavior once you can engender that trust-seeking behavior where they feel you care, where they matter, right? And then that also breeds the word of mouth and it spreads and other people will come and say, well, listen, I know you helped this person out. Can you help me? And you have a team assembled that buys into that and continues to engage in the community. That is an investment. That's not a 1-year investment. That's not a 1-month investment. It's taking 7 years to do that. And so organizations that have been deep-rooted for more than that, like the ABC, it matters. And as Chloe mentioned, APN, it matters. So we need to kind of, switch our healthcare hats and what we think works and society from a societal standpoint to having a community engaging or interfacing kind of healthcare model where from when we're trained, going back to our medical school curriculums, going to our nursing school curriculums, I think this is not something that we change when we're, attending, because time is something that's not easily afforded to us. But we need to change those curriculums as well, where this gets incorporated early on so people can see where the future of medicine should go. And that's how we start having those tough conversations too about some of the lenses that have been created that have prevented such customer facing or community engagement or building navigators, community navigators that can help us address some of these issues. And so I'm glad that we're having these conversations now.
And I might ask, just as you brought up the educational component of it, or the medical education component of it, are any of you aware, are there schools that are taking that in and redoing the medical curriculum, the nursing curriculum to incorporate some of those perspectives, or is that still work to be done? And probably
there's a lot more to be done. Peripheral arterial disease affects, it's the numbers are varies, and this is part of the problem. People say 8.5 million, people say 20 million. We can't even get our prevalence straight. But I digress. The problem is that majority of providers are not even taught about peripheral arterial disease in their curriculum. If you look at anyone who's internal medicine boarded or cardiovascular disease, going back to your medical school, I can tell you in 4 years of medical school training, I had about 1 or 2 questions in my entire 4 years. If you go to a lot of cardiology clinics today, if you look at cardiology fellows, if it's not a vascular focused clinic, I mean, how many patients are being told to take their socks off when they go see a cardiologist today? Because people think that cardiovascular disease stops at the belly button, right? So these are the simple things that we need to readdress when I talk about curriculums. And so people like us on this panel and to your credit, the Medical Alley, having podcasts and webinars, awareness is very important. But also we need to go to medical schools, not just societal meetings to have these conversations. I think we need to take societal meetings to medical schools, to nursing programs, and have those type of interaction, educational opportunities to teach them. And hopefully that would lead to changes in their curriculum.
Yeah, I was just gonna add actually. So I would say everything Dr. Fakarini mentioned is on point. The generational impact and really the generational focus, more importantly. But to your question about education and how are we really aiming to revamp our medical curriculums, both for nursing as well as medical school, I would say that the only way to have such a revamping is going to be to diversify the medical field. We have to diversify the workforce. So a lot of the particular conditions that Dr. Fakarini mentioned, such as peripheral arterial disease, we know that those conditions disproportionately impact some groups more than others. But in order for us to acknowledge these disparities, we actually have to make sure that there's a diversification of those that even at the highest level in medical schools that have leadership roles. So we have these conversations at the table and make sure that the curriculum is focused on the community at large. Why is it that the majority of people who have cardiovascular disease come from communities of color, but when you actually look at cardiologists, we only make up a very select percentage. And I think that that's why organizations like the Association of Black Cardiologists are really going a long way, because they're showing the true faces of what cardiology hopefully should look like. And we know that there is volume or there's power in numbers. And when it comes to making sure that we're caring for patients, these most vulnerable populations, we do want to make sure that there is a concordance between both patient as well as clinician. And furthermore, I will say that a lot of medical schools to date are actually giving a lot of courses on, at least at the level of racial and ethnic disparities. So I am hopeful that that teaching is going to actually improve outcomes for our future physicians as well as our future nurses as well. We also know that the more we diversify the workforce, those that don't come from those communities that we are specifically talking about today on this webinar are actually going to be more empathetic to caring for the communities, doing everything that Dr. Fakarini mentioned that he does, getting to the level of why they may not have the opportunity to get to the doctor, or that they don't understand why maybe this particular condition is occurring in them and has generationally occurred in them, because many a times people think that it's normal for everyone in their family to have diabetes. And we know that we can actually change that just by ensuring that the health literacy is there, but having those conversations to understand where the limitations as to why they weren't able to get the resources in place to get rid of that particular medical condition is just not available or made available to them. So I'm hopeful that we are making these changes. I'm hopeful that our medical schools are understanding the importance of needing to have this education, but I do think we still have a long ways to go.
Indeed, so that would make me think it's incumbent on us as a healthcare and health technology to community to continue pushing those efforts and ensure we don't slip back. Chloe, I'd be curious, you'd mentioned the community engagements and the work that you and your organization have been doing. I'm thinking about the education side, and Dr. Fakarini, you brought this up as well. Is that sort of approach to medicine of being in the community and engaging more broadly, is that a gap as well in the way we teach nurses or doctors to practice? Or are there opportunities there to better engender that as part of the strategies that we use?
Well, I would say that the healthcare system as a whole is not set up to embrace preventive medicine the way that I think that it should. So that right there is an issue. Now, we all know that we don't learn everything that we need to know in school. And I want to add to what Dr. Fakarini and Dr. Bond said previously regarding education. We all get continuing education outside, once we're in practice through our professional organizations. And I think that our professional organizations like the ABC and the NPCNA and other organizations really need to think about embracing cultural and racially competent education for healthcare workers, because this will help us to improve on how we engage with the community. And also healthcare organizations, hospitals, clinics, making it mandatory for new hires to go through cultural and racial competency training. It's something that I feel is very important and that is lacking in a lot of places.
Indeed. I'm starting to hear, I think, a couple of, I'll call them like high level core areas where it sounds like you're suggesting that we should continue to push and do work in. And tell me if I'm hearing this right. So, one is the educational piece, both the medical education and then, as you just pointed out, Chloe, the continuing education. The second, community engagement strategies, but recognizing, right, each community, as you pointed out, Dr. Fakarini, is unique and different. And so it can't be one size fits all. And then the structural components of the way healthcare as a system has been built and designed, and the broader structural racism in society and how we pull that apart. It sounds like in those three areas, there are bits and pieces, there are pieces of work being done, but so much more to do. One thing I'd ask then of the three of you, we have a large health technology community, right? So Medical Alley covers the care delivery and payer side as well as the technology side. I'm sure you all work with a number of these organizations in different ways. What might you tell them that they could do to better contribute to pulling these levers or moving this effort forward? And Dr. Fakarini, I saw you come off mute, so I think you might want to say something.
Technology. Yes, we're very appreciative of technology. And I'm just going to start off saying that technology is needed. But I need to explain not only what I do from a technology standpoint, it's, we mentioned all the contributions that we've had in medicine for 20 something years. Technology drove a lot of that. But, the folks who are not receiving that technology or who are not included in the research studies that include those technologies are people that look like your doctors on these panels today, right? So the patients are not included. So it's not just developing technology. It's not just telehealth. We need telehealth, right? So I'm going to park that aside. I think we know, but can the patients in the Mississippi Delta or in Louisiana or in Arkansas or in Tennessee or in West Virginia, do they have the broadband to receive that telehealth visit, or that technology that's being developed, has that been looked into in that or those patient populations? So my advice to anyone in technology is that, again, just as Chloe's mentioned, if you are not invested in those communities where you brought your technology and you've lived in those communities, not for a month, not for 2 weeks, you've tried that technology in there for a year or 2 years, and you've gathered information and you've taken that back to Silicon Valley or wherever you are, and you've made sure that, regardless of where this patient is in this country, I know that they're going to have access to this technology. If you can do that, I think we can see a significant impact. But if it still favors one group over another, you are just exacerbating those structures that we just talked about.
That theme of community engagement comes up again. Yeah, indeed. Any other thoughts there? No. Or Dr. Bean, please.
Yeah, no, I was just going to say, just to echoing that sentiment, is making the technology accessible, but I also think it's important that the messaging has accuracy. I would say that, many of our patients do use technology sometimes that may make it a little challenging for us as clinicians when it comes to the messaging around cardiovascular disease in general. And I think that if we have these advances to get messaging out there to a broader population through the excellent use of technology, we just want to make sure that the messaging is coming from somebody who is trustworthy, and that the messaging is also empathetic to those populations that we really want to target the messaging for. So again, driving in communities of color, making sure that the messaging maybe comes from somebody who they can identify most with. So from a technological perspective, we are seeing so many advances when it comes to cardiology, even with the use of artificial intelligence as an example. But we know that even with that, there are some biases and limitations. So I think as we develop more and more technology, just being thoughtful of those biases that are even underscored in something as simple as AI as an example, but also, as Dr. Fakarini said, making sure that we're including patients into the research trials or the pilot trials that we're going to actually place this technology on.
Oh, wonderful. Thank you. And maybe the last thing I'll ask before we come in to wrap it up, the topic of policy and politics had come up a little bit at the beginning. And that's another area where there's a lot of work that, those of us in the association world often do. But, I say this as a former lobbyist, what we're usually good at is whatever needs to be done, we'll go do it, but we can't tell you what needs to be done. So I'd ask, are there any suggestions or directions you might point us in on the policy front of areas that, if they were adapted or moved forward, would make an impact? And Chloe, I might start with you.
The policies or proposed legislature that focuses on access, I would stress, is the most important. Anything that's going to decrease barriers to care, that's something in my practice that I run into quite often, is the time that it takes to complete a prior authorization, or if I don't have the staff to help on a particular day. At Tulane University, they recently opened a multi-specialty pharmacy, and that pharmacy helps with getting medications that require a lot of insurance information, prior authorizations, et cetera. And I just was able to get the drug Leqvio for a few of my patients through that pharmacy. They helped with all of everything that I had to go through to get that medication. So that was a big help. But we need more support in that area to make the resources available to clinics and hospitals and practices so that we can give our patients the medications and treatments that they need.
Indeed. Dr. Bond, any thoughts from you?
Yeah, in addition to access, I think it's important that we preserve the clinicians that are taking care of patients. And I would say at the top of that really needs to be making sure that we don't have reimbursement cuts for physicians when it comes to, we know even coming up in the next incoming year, possibly Medicare cuts. How can we do that? How can we get more people to go into the medical field if we're not going to be actually providing them the actual amount that they deserve based on taking care of these particular patients? And we know that even when we look at care deserts, so areas where we are limiting the number of physicians, we know that that's where the cuts are probably going to be the greatest. So it's sort of counterintuitive if you think about it, that in areas where we need the most number of clinicians, we're going to be probably doing the most amount of cuts when it comes to reimbursement. So I think that at a policy level, that's very, very key, very, very important. I also think that we have to think about the restructuring of healthcare. As Dr. Fakarini mentioned right now, we think about it in the sense of diagnosis and treatment as opposed to wellness and prevention. And I think that it's going to take time to make that actual long-term change, but that change is going to actually decrease the number of morbidity and mortality that we're seeing, especially when it comes to these very preventable conditions like cardiovascular disease. So I would say the top two is making sure that the physicians and the clinicians out there that are doing the work are getting the reimbursement that they deserve. And then secondly, restructuring the healthcare system to focus on the wellness and prevention aspects as opposed to the disease and treatment aspect.
Dr. Fakarini.
Yeah, I think one is to make sure that we keep people like myself, Dr. Bond, and nurse practitioner Villavaso still in practice in our communities that we engage in. This whole concept of, robbing Peter to pay Paul does not exist. It's so antiquated in 2022. And that's why some of us are involved in policy, irrespective of where you're on the cardiovascular spectrum. I mean, I think you're being hit right now with the way things are structured. And that's why having a voice and having a seat at the table matters. Having people who represent these communities matter. And that's why, it's not, you can't be what you can't see. So having committees that are structuring who participate in advocacy and policy have to have a broad spectrum of representation, including people of color, but not just in your DEI departments. That's one. Number two, I've always said that there are people who we hope could have, change of hearts in terms of how they practice. For instance, in the peripheral arterial disease space, I've mentioned how some people are offered 50 to 60% of patients who undergo an amputation to date have not had any appropriate vascular workup, or even are not even offered a revascularization strategy. And these patients who undergo an amputation, majority of whom could have been prevented, 90% could be prevented. Majority of these patients will be dead in about 5 years. And there's nothing called a minor or major amputation. I know technically in the book it is, but imagine if I tell you you don't want to lose a toe. That is just inhumane. So you talk about injustice in healthcare. My job is not to change people's hearts now, but restrain the heartless. And so policy matters. Going back to the civil rights era, those policies that were in place to try and stop the injustices that were occurring in these communities. The same thing does exist in healthcare. If you look at our maternal health rates, if you look at even asthma rates in these patients, there were policy drivers that led to these social determinants that are leading to early deaths in Black and Brown communities. So I don't care how smart you are or your academic background. The solution is not just what you have from a medical standpoint. What do you bring to the table from a policy, social determinants and political determinants? And so the voting structures, the government, the policy, and how are we involved as medical participants in those structures? What voice do we have to impact change? I think that's where it starts. And having discussions like this matter as well. So I think those are the top two for me from that standpoint.
Yeah, I'm reminded of when I started in the lobbying world, my mentor would often say, if you're not at the table, you're soon on the menu. I think you are all reinforcing in that it's very important that the right people are at the table to have those discussions and to make sure that in developing policies, we're not unintentionally or intentionally excluding entire swaths of our community. So I appreciate you all sharing that. We got a question in from the audience that I think is apropos for the group, where an individual asked that they're applying to medical school next year, and she is wondering what can she do as hopefully a future medical student to advocate for better curriculum and be proactive in learning about cultural awareness and equitable approaches to medicine. Any advice or recommendation you might give?
I can start. So I think as medical schools are evolving, and I can speak actually personally for myself, because I'm working with my own local organization on creating a medical school, and we'll be having a new incoming residency program for internal medicine as well in the upcoming years. With that being said, as we are evolving and building, and the need to build more and more medical schools to get more and more doctors out there in the community, we know that we are incorporating the students into the curriculum as well. So when you go to the medical school, it's important that if you see your curriculum doesn't have classes on implicit bias training or cultural competency training, or even the curriculum doesn't necessarily paint the stage for these disparities that we addressed, race, ethnic disparities, sex, gender disparities, then vocalize that. Bring it up to your dean of the medical school and make sure that you have at least the support from them, those in the leadership sector, to actually revamp what that curriculum would look like. To that point, areas that you may want to look to are the societies that are out there actually really providing the messaging. And really the goal of the societies is that a lot of the messaging that the societies provide, our hope is that that will be trickled down into the medical schools or the residency programs or the fellowship programs as well. So there are a lot of resources out there. It's just a matter of bringing it to the attention of those who are making the decisions when it comes to the curriculum. But please feel empowered as a student that will be applying to those schools, that you ask that basic question even on your medical school interview, because I think that that's an important question for you to ask, and hopefully that will guide if they're open to the flexibility of, if they don't have that to date in their curriculum, are they open to actually modifying their curriculum? And my hope is that the answer will be yes.
Thank you.
And just to add to Rachel's great point, you know, joining organizations and having mentorship in these organizations are important. For me, as a student, it was the SNMA for me at that time, and now leading to the ABC. And so the Student National Medical Association, Association of Black Cardiology, work in concert, by the way, with the parent National Medical Association, leading on a higher level. I think it's you know, coming to those meetings or allyship collaboration and getting involved by knowing how to ask these questions, right? It's not just going in and asking these questions, but what would be the best approach to really affect change, and building a coalition to do so, or giving tips and advice on how to do that. So I think that's one. And also number two, you know, the onus should be on the leaders of these medical school programs, to have divisions that are intentional whenever they go out to recruit, to have these students participate not only in-house, but also in the communities. You know, I was glad to come from a program where, you know, community engagement was huge for me as a medical student, which gave me the foundation to be able to one day say, you know what, I'm packing my bags and going to the Delta. So credit to them, but also those mentors that guided me through that. So those are all important steps to take.
Thank you. And Chloe, I might ask you the last question. We've heard a range of perspectives. I think a couple of core areas that, you know, if I do a summary of this, that we might focus on: community engagement, the education side, both in school and continuing education, the structural issues, structural racism in the way healthcare is built, and then the political environment. To our audience that is out there, you know, if they want to get more engaged, learn more, or find out even how to plug in with, say, PCNA or ABC, what would you recommend they do? Or are there places you might point them to say, hey, here's where I could go to bring activities or bring ideas into my practice or into the work that I'm doing?
I would recommend accessing both organizations' websites. There's a wealth of information there for nurses and other healthcare providers that want to get involved. There are links there that are available. You can get involved in local chapters within PCNA in particular. But one other thing I would like to leave the audience with, and that's the fact that we have to remain transparent on this issue, okay, and deliver the data in a frank, honest way. I'll share a comment that I heard on a previous presentation where someone felt that the data on PCSK9 inhibitors and how they're administered, well, the prescription rate for Black individuals, with that being lower than for white individuals, that information shouldn't be given or delivered in that manner. And it was felt that it caused division. And one thing that I just want our audience to know is that this is not about dividing. We're actually trying to do the exact opposite. We're trying to make healthcare equitable, make it accessible to everyone. It's a right that everyone should have. And so that's what we're here trying to ensure. And if we sugarcoat or dress up the nasty, ugly data and even the nasty, ugly past of our country, we're not going to make the progress that's needed.
Indeed. Thank you for that. Yeah, if we're not willing to confront the brutal truths and be honest about it, this will be a problem for much, much longer. Mm-hmm. And I think on that, I'll say a thank you to all of you for sharing those perspectives, sharing that information, and helping us better understand what is happening and what might be done. And to the audience that's out there, I'll say thank you for spending a bit of your day with us today and hearing this discussion. Please, if you have ideas for other topics we should address, I think I got a couple from the panel today, let us know. This is a conversation that I'm committed to, and Medical Alley is committed to continuing and to incorporating in our political and advocacy work and our business development work and our ongoing activities. And so with that, I will say thank you to all of you, and I hope you have a great rest of your day.
Thank you.
Mhm.
Thank
See
you.
folks.
Thank you so much.
Bye.